Hello all, I'm Deborah Matthews, the Assistant Director for Science Programs in the Berman Institute of Bioethics and the Ethics and Governance Lead in the Institute for Assured Autonomy. I'm delighted to welcome you to what is a new quarterly series co-presented by the Institute for Assured Autonomy and the Berman Institute of Bioethics, featuring national scholars presenting new research and development at the intersection of autonomy and assurance. I'm thrilled to be able to introduce my colleague, Dr. Kadija Ferryman, to present her talk, Race Matters in Health Data. Dr. Ferryman, who joined the BI last year, is a cultural anthropologist who studies ethical, social, and policy dimensions of digital health technologies. Including examining how technologies such as genomics, electronic medical records, and AI impact health injustices such as racial health disparities. Dr. Ferryman is core faculty in the Berman Institute of Bioethics and assistant professor in the Department of Health Policy and Management. She came to us from NYU's Tandon School of Engineering. And before that, she started her professional career over 20 years ago as a policy researcher at the Urban Institute in Washington, D.C. She's an affiliate of the Data and Society Research Institute and at the Center for Critical Race and Digital Studies, as well as a non-resident visiting scholar at the Urban Institute. I'm excited now to turn over the stage to Dr. Ferryman. I look forward to your talk, Kadija, and to our discussion.
Great. Thank you so much, Deborah, for that introduction. And let me share my screen. All right. So hopefully everyone can see that. So again, thank you so much, Deborah, and the entire IAA and the Berman Institute for inviting me to give this talk today. I am honored to be in your presence today. So even though we're virtual today, I'd like to begin my talk with a land acknowledgement, and I invite you to join me in acknowledging the Lenape community, who are the indigenous stewards of the land we now call New York City and where I currently reside. I also invite you to acknowledge the Seneca Village community, a predominantly African-American community that was displaced to build New York City's Central Park. And these acknowledgements, if you've seen them before in other kinds of talks, people starting their talks with these kinds of acknowledgements, they prompt us to remember historical displacements and erasures, and hopefully also prompt thinking and action to dismantle their ongoing legacies. All right, so I'd like to start my talk today with the title, Race Matters in Health Data. And one meaning of that title is that race is important in health data. But I want to parse out another meaning of race matters that brings us closer to the word matters as in substance or material. I want us to think about the title as also referring to how race becomes matter, specifically in the ways that processes of racialization become material in health data. The two meanings of the word matter, as in substance, and importance are linked. Matter is substance, and therefore substance must be contended with. So when we bring these two meanings together, substance and importance, we come to a third meaning that's embedded in the title of the talk today, that race, because it is made material in health data, must be contended with and demands attention. I'd like you to keep these threads in mind as I go through the talk today. So I'll begin with the way that race is often raised as being important or mattering in health data, and that is through the absence, missingness, or non-representativeness of data sets. I'll then take us to a different view of race matters in health data, not as lack of representative data, but how and where we can see processes of racialization in health data. I will then conclude with some thoughts and provocations on how we can contend with these race matters in health data. So not too long ago, I was at home, like many of us are now, in front of a laptop watching a conference online. And the topic of this conference was artificial intelligence in health. And the speaker was discussing the development of a machine learning tool to detect prostate cancer. During the question and answer portion of the talk, I asked how health disparities in prostate cancer had been considered during the development of this tool, since it hadn't been mentioned at all during the talk. And I knew that race mattered in prostate cancer, since I have a number of relatives dealing with the disease, and I know that racial disparities exist. For example, Black men have higher incidence and mortality rates of prostate cancer. And research has also shown that Black men are less likely to receive treatment that follows prostate cancer care guidelines. They are also less likely to receive diagnostic MRIs and experience a longer time between diagnosis and the start of treatment than white men. And although there is some research on biological contributions to racial differences in prostate cancer, there's also evidence showing that Black and white men who receive similar care have similar outcomes. When I asked this question about health disparities, the response I received was that the team used a representative data set. And I was unsettled by this answer. Now, I know representative data sets matter, especially for developing new cutting-edge tools for medicine. So for example, clinical trials are notorious for not being representative. And as an example, the field of genomic medicine includes a number of cases and illustrative examples of how the lack of representativeness can lead to harm for racial and ethnic minority groups. It's also clear that lack of representation matters for other kinds of health data too, such as images of skin used in dermatology and oncology. There's evidence that a lack of diversity in images of skin is leading to bias in AI tools to detect skin cancer. The lack of images of skin conditions on dark skin also prompted the grassroots effort Brown Skin Matters to make these images more representative and more useful for more people. So yes, data representation matters in health, but is that enough? My answer is no. And that is because it's not enough if racial and ethnic groups are present in the data, but it matters how they are represented in that data. It also matters how this data is understood and interpreted. As I mentioned before in the previous example of prostate cancer, Black men are less likely to receive care that adheres to clinical guidelines. So this example shows us that race matters when it comes to the kind of care one receives. And it's also important to note that clinical guidelines and the care that is given is also represented in health data. Thus, guidelines and care shape how people are represented in clinical data, not just whether they are represented proportionally or not. This became clear for me a few years ago when I was conducting research for the Fairness in Precision Medicine study, along with my colleague, Michaela Pitcan. Our research focused on understanding how this emerging field of data-centric medicine might lead to disadvantage or might follow along existing pathways of marginalization and discrimination in healthcare. During this study, one of our interviewees explained to us how race matters for clinical guidelines and how that in turn shapes clinical data. I'm going to share an excerpt from our interview with him, with you. So he said, here are the guidelines for lung cancer screening. You must be 55 to 80, and you must have 30 pack years of smoking. This all came from a study, and of those 53,000 people, only 4% in the study were African American. So now we have lung cancer screening guidelines based on that 4%. He went on to say, you don't have to smoke a pack a day if you smoke menthols. So now when I do lung cancer screening in the community, most of the community members that we screen don't qualify because they don't have the smoking history. So here in this quote, he does talk about lack of representativeness in the data set, but I think this quote, we can also use this excerpt to tease out why representative data sets might not be enough. We can see in his quote an argument that because of the way the guidelines were developed, some Black people were not screened. The guidelines, of course, did not affect whether or not people got cancer, but instead may have affected how far their cancer progressed before detection or diagnosis. Thus, the clinical data can reflect this lack of early screening, since it is reasonable to think that those who were not able to be screened early would present with cancer at more advanced stages. So here we see the issue is not that certain groups, particularly minoritized populations, are not in the data. It's a matter of how the clinical data itself represents patterns of racial discrimination. It follows that a data set that is representative by population groups is still stamped with this history. And without knowing why the data looks the way it does, a number of seemingly reasonable patterns could be identified and conclusions could be drawn. For example, it might be reasonable to conclude that there's some biological or genetic difference that causes Black people to present with lung cancer at more advanced stages with fewer pack years of smoking. But the knowledge of the data's history and context would lead one down a different path. So we were told this history of the screening guidelines and how they disadvantage patients when we were doing the research for the Fairness and Precision Medicine study between 2017 and 2018. But our interviewee, when he told us about these guidelines and these problems that he had been seeing in the field, he had known of this history, the history of the data, how it was collected, and the resulting impacts. He had known of this for much longer, from before 2017. But it wasn't until recently, 2021, last year, that lung cancer screening guidelines were changed. The US Preventative Services Task Force lowered the number of eligible smoking years from 30 to 20, and the age of screening lowered that from 55 to 50. Additional research showing racial disparities in screening guidelines helped to shift these screening criteria. And according to this research, of those diagnosed with lung cancer, 32% of African Americans had been eligible for screening versus 53% of whites. This screening example shows us that race matters in health data and that patterns of marginalization materialize in this health data. In other words, it shows us how clinical data can be racialized. And racialization, as described by anthropologist Kiera Bridges, is a process in which, quote, ideas about difference become visible and tangible, reflected in the material conditions within society. Material and societal conditions appear to affirm the veracity of ideas about race. And so this quote is interesting because it outlines the process of racialization as in several steps in showing how ideas go from just being ideas to becoming material, becoming evident in society, and then how these tangible representations of these ideas themselves gain more force to add more force, more truthfulness to those ideas. So it's this circle of concepts, ideas, and material conditions and how they reinforce each other. And there are other examples of the ways in which clinical data are racialized. Over a decade ago, clinicians also began raising questions about racial corrections in clinical data, specifically the eGFR, that is a calculator of kidney function. This calculator uses a race multiplier to adjust for the supposed higher muscle mass of African Americans. This article here from 2011 raised questions about the clinical data that informed this multiplier and whether it was scientifically valid or not. And almost 10 years later, Vyas and colleagues published the first comprehensive examination of racial corrections used in medicine. And here is an excerpt from the longer table of multiple racial corrections that they included in the article. that are used in multiple specialties from oncology to cardiology. And the authors of this paper also question the scientific evidence undergirding these corrections. And here is an excerpt I'd like to share with you, an excerpt from the article where they discuss a common risk score that's adjusted by race. They talk about a risk score that was developed by the American Heart Association that predicts the risk of death to people admitted in the hospital and assigns 3 risk categories and categorizes people as being lower risk depending on their race. But they highlight here that the American Heart Association, because as they went through and compiled all of these different clinical risk adjustments that are used, they also looked into the evidence for these calculators. And they found for this particular adjustment that the American Heart Association didn't provide a rationale for adjustment, but clinicians are advised to use this risk score to guide decisions about referrals and allocation of healthcare resources. And since Black race is equated with lower risk, following the guidelines could direct, as they say here, could direct care from Black patients. And so the authors here with this excerpt argue that corrections shape what could be seen as, or broadly understood as, objective clinical data. But they also highlight here that these racial corrections are a matter of justice, because some of these corrections can further health disparities and health inequities. And on continuing on this topic of race multipliers and racial corrections, it wasn't until recently that major hospitals in Massachusetts had decided to stop using the eGFR race multiplier. And here's a tweet from medical student Lash Nolan, who announced the change. But as one commenter on this tweet highlighted, the commenter here asks, I was wondering the same thing about major clinical algorithm apps, if they will also remove race-based weights from their platforms. And so the commentator here is pointing out on the thread that not only are these racial corrections still used by other hospitals, but they're also still used by apps that use these risk calculators. And it's unclear if they will continue to do so. And so this query, I highlight it because it should prompt our attention to clinical data's mobility, moving from EHRs to apps to predictive models and other analytical tools. And with this query, I also want us to think about, as these data move and are moving, how do these legacies remain embedded in the data even as they move to different contexts? And these are just some examples of a breast cancer risk assessment apps that use some of the racial corrections that were mentioned in the article by Vyas and colleagues. So I want to share another example of race matters in health data, this time when race is not even present as a variable. So hopefully by now, we all know that the COVID-19 pandemic has not affected everyone equally and has mirrored previous patterns of health disparities in the US. But recently, Schmidt and colleagues explored the way that racialization affects clinical care, even when race is left out of the data. So their examination focuses on clinical risk calculators that are used to determine the allocation of ventilators, a critical issue during the COVID-19 pandemic, of course. These calculators use creatinine, which is an indicator of kidney health, to compute scores that indicate the patient's chances of survival in the near term, as well as their overall life expectancy. The authors argue that the use of creatinine in these calculators disproportionately and unfairly put Black people at a lower priority for receiving ventilators. This is because they argue that creatinine is not just a physiological measure, but also, quote, measures social disadvantages that may cause higher creatinine, end quote. Higher levels of creatinine, they argue, result from chronic conditions such as kidney disease and high blood pressure. And the prevalence of these conditions in racial and ethnic minority groups can be attributed in large part to social determinants of health, and can be, as they say, best understood as the consequences of health inequities and structural racism, end quote. So here's another example of where race matters in health data, even when race is absent in this kind of calculator. Again, more representative data sets may not do much to address the issue that the authors point to here. So now that I have taken you through these examples of racialization in health data, from screening guidelines to clinical corrections and risk calculators, the question might be, well, if data representation is not enough, well, what else should we be doing? So I do have a few suggestions in this regard, including sort of thinking about how we can contend with race matters in health data. The first recommendation is that we shift our language around data problems, because how we talk about problems shapes and structures our universe of solutions. So as my former colleague at the Data and Society Research Institute, Kinjal Dave, argued, we should stop overusing the word bias. When we stop overusing the word bias, we can begin to use language that has been designed to theorize at the level of structural oppression. By using the language of bias, we might end up overly focusing on the individual tenets of technologists involved, rather than the structural power of the institutions they belong to. We need to move away from a language of bias, since it implies local technical fixes for the data, when instead we should be looking at how institutional and systemic factors shape our data. Similarly, scholars Stephen and Keyes argue that we should focus not just on biased data sets, because, quote, the data sets themselves are not so much biased as they are reflective of the sites of their use, and that we must instead focus on the logics and systems of inequality that lead to the data set's purposes, and so naturalize their demographic skews. And that's a quote from Stevens and Keyes. So I suggest that we begin to think and speak about our data as not just as biased, but as racialized, because that term of bias is reductive and leaves out these, again, as Dave and others argue, these structural and systemic patterns of oppression. So when we approach our data as racialized, then we can ask questions about the data's history. By thinking of clinical data as racialized, we also don't have to take the normative position that race variables are bad, or that racial differences in data are bad and should be expunged from clinical data and not used in the tools that can be used to develop tools from this data. Instead, we can begin analyzing these data with our eyes open to the ways that race is represented, imprinted on, and animates this data. So what follows from this is that we can ask questions such as, what histories are represented in this data? Does this data represent current processes of marginalization? And asking these kinds of questions as we begin a process of data analysis, development of AI tools or other tools for health, asking these kinds of questions would be part of an approach for data ethics that is related to, yet distinct from, bioethics. Data ethics in this vein, in this approach, as historian Joanna Radin argues, begins from the notion that, quote, before it is possible to determine the best practices for the appropriate use, reuse, and maintenance of data, it is imperative to understand how data comes into being. So what we can take away from that quote is, yes, questions, of course, of appropriate use, reuse, privacy, confidentiality, security are, of course, important ethical issues to consider when we're thinking about data. But this kind of data ethics that focuses on the origins of data, on the histories of data that are imprinted into the data, leads us to ask about different kinds of questions about the data, alongside some of those concerns about privacy and confidentiality and security. It also approaches data ethics as starting with, quote, data empathy, which was a term that was described by an engineer that we interviewed for the precision medicine study. He used this term, this engineer, to describe his own desire to be closer to the data as he was doing his work. He felt like he was almost sort of working with this information that he was a stranger to. He wanted to have a better sense of where, and a better understanding of the data, where it came from, how it was collected, and what its purposes were. So this kind of data ethics means that health data analysis projects must take data's history and context seriously. To do this, teams designing AI tools for health may also need to expand to include anthropologists, sociologists, historians, and others who can provide essential information about data histories, contexts, and social processes that animate the data. Expanding networks of expertise may also prompt critical reflections on how some of these same histories and current discriminatory and exclusionary practices factor into whose values, worldviews, and experiences, not just technical know-how, are shaping the ways that analyses are done. And so this is important, again, to highlight this point that we often think that tools are developed just based on the technical knowledge and experience of those who are making them, without fully acknowledging, again, how values and different experiences are also brought into that process. So what are race matters in health data, and why does race matter in health data? I've tried to show that health data are marked by, reflect, and shape systems of power in society. When we shift our language and our frames, moving from bias to racialization, and again, to other terms similar to racialization, other terms that can index practices of social exclusion, social marginalization, we can open up new possibilities for understanding as well as for action. We open up new paths for the data work that we all know matters and should matter for everyone. So I will stop there. Thank you so much. And here are my references. I'm happy to share this with you all after.
Terrific. Thank you so very much. So we have a couple of questions in the Q&A, and I have a couple of questions of my own. I'll just take a moment to remind folks that you can add questions to the Q&A. You can upvote questions there, so please feel free to do so. So the first couple of questions from Kevin Cropper in the Q&A include one about sort of how expansive is this use of race in calculators and guidelines? Are there similar coefficients to the kidney numbers for other races, or has there been like a focus of this kind of adjusted system primarily for Black folks in America?
Yeah, so that's a great question. And, it takes me back to the article that was published in, it was 2021 or 2020, that, again, if we sort of think about the history, right, that this was the first article to really put in, that I know of, to put in one place all of the different racial corrections that are used clinically in medicine in multiple specialties. And the answer to the question is no, it's not just these racial coefficients are not just used in for African Americans or people who are viewed as Black or identify as Black. There are also racial corrections for other racial and ethnic groups. And so, for example, one of the corrections that is another example of a correction where it's not just a correction for Black individuals, is also the correction for lung function. And in that case, there's a correction made for individuals who are identified or identify as Black, as well as individuals who are identified or identify as Asian. And in those cases, in that particular case for lung function, it sort of starts from data showing that on average, people from those populations have lower lung capacity than people from white populations on average. And so there's this sort of idea that Black and Asian people have lower lung capacity. And so when one goes into the hospital to get your lung function tested, depending on how you identify or how your race is identified by a clinician or someone else, your sort of absolute reading is then adjusted based on that coefficient. And in that particular case, it happens for people who identify or are identified in one of those two groups. And, this particular coefficient has a really interesting history. There's a book by another historian called Lundy Brown, who wrote a book, Breathing Race into the Machine, The History of the Spirometer, from plantation to kind of genetics. And I didn't get that title exactly right, but this was a book Lundy Brown wrote in 2008. And similar to some of the examples that I highlighted today in the talk about the EGFR, for example, where you had some clinicians raising this question of why are we exactly using these corrections? And then it taking a decade or more for these to be addressed, with the example of the lung function testing, for example, and then it taking years for those differences to be addressed. Lundy Brown wrote this book, essentially showing that this idea that Black and Asian people have, smaller lungs. She kind of traced that history to plantation and slavery and ideas, kind of racist ideas about inferiority of Black bodies, of Asian bodies, and then how those corrections were then used, right? This idea that as there was a switch in sort of the economy and people were moving into more industrialized jobs, there was this idea of, well, that actually plantation labor was better for the supposed smaller and weaker lungs of Black people, right? So that's why they were more suited to jobs, not in the new kind of industrialized economy. So it's also interesting, the sort of history of how these tools were developed, and then how they were applied and how they were used. In that book, Lundy Brown also highlights an example in Baltimore, where, of course, Johns Hopkins is located, where that same racial correction was used to deny compensation for a multiracial group of plaintiffs who were suing a company for exposure to asbestos and lung damage. And in that particular case, the company looked through and found that, oh, wait a minute, there's this racial coefficient that shows that, Black people's lungs are different. So we can actually, say that essentially Black people's lung, they have to sort of show more evidence of lung damage to be compensated through this particular suit, right? So, these racial coefficients, not only are they used in kind of multiple specialties and with multiple racialized groups, but they also have been applied in settings outside of clinical medicine as well.
Thank you. So interesting. And I wonder if I could extend on that just a little bit before turning back to the Q&A about the reach of these corrections or coefficients outside of the US. Is it is there something specific about the US context? I mean, there are many things specific about the context, but like how far reaching are those kinds of adjustments in medicine?
Yeah, that's a great question. And I'll go back to the example of the lung function, because that's the one that I know, sort of know the best. And the coefficients that were kind of developed, they were, so there have been different iterations of this racial correction, and the sort of latest data was based on kind of an international sample, right? So the idea is that these coefficients could be applied globally. However, one of the issues that I'm working on on a paper with some colleagues at Hopkins on this very topic. One of the problems that we're pointing out is that, of course, race as a social construct is understood in different places in different ways. So even if you look at who is understood to be Black in the US and the UK, there are some important differences there, or who's understood to be in the Asian category or not, which is again the groups for whom there's some change. There's a change there. So that's an important point to keep in mind as we think about the international applicability of these and how far they extend. The other is that if you could plausibly say, if there was a way for one to really do a representative, very robust study of populations across the globe, and even if we were, able to come to some kind of global agreement on racial groups and what they mean, all of these things, right, seeming kind of like a heavy lift. We also know from history that within countries, understandings of race shift over time, right? So even if you were able to kind of develop a set of coefficients that could be broadly applied, that would only potentially be for, a certain number of years before our societal views of what race is and who's in what racial category, really shifts. And then you also have issues that, other points of like people who are mixed race, things like that, right? How do you use those categories? And my, this is something that has, come up as I've been, for example, when I did my dissertation research, a nephrology fellow who was of Latino origin talked about how, she was, learning during her fellowship and wanted to know how the EGFR correction, because there's a correction for Black and white, but not for any other groups, right? How is it used for Latinos, for example, who could be of, either racial group or a mix? And the answer that she, got was, well, the clinician sort of decides based on what the patient looks like. If they look like they have more African ancestry, then they'll use the, correction for people of Black ancestry, or if they look more white, or depending on what they tell them. So even the sort of current use of how these coefficients are used and deployed clinically right now also kind of poses some problems as well. There was the article that I quoted, one of the articles about COVID-19 ventilator allocation. One of the authors on that paper is Dorothy Roberts, who is a fantastic scholar of medicine and race and technology. And she opens one of her books, I believe, with this story of a clinician sort of seeing a medical image and walking by and saying, oh, who's the latest cystic fibrosis case here, right? Just by looking at the image of the chest X-ray. I don't know if it's X-ray or MRI at the time. And, there was this look of astonishment across the other clinicians who had been gathered. And that was because this was an image of a young Black girl who, for months, clinicians were sort of wondering what was wrong with her. And cystic fibrosis had never entered into their universe of things that could be wrong with her, because of this idea that, cystic fibrosis is not something that Black people get, right? But without seeing the race, someone walking by and just seeing the image, they were able to sort of very easily diagnose or, see what that was. And so that's not, exactly aligned with the idea of racial corrections, but just this idea of how clinically we see some of these ideas of race and difference get wrapped up and deployed in ways that are unexpected and sometimes harmful.
Yeah. In light of sort of this international reach that you've just described, John Noel Viana asks, is there coordination between the US, Canada, the UK, et cetera, regarding guidelines on racial corrections for assessing health status?
Yeah, I'm not sure about that. But again, I think that, if there were to be that kind of coordination, I think it would be more than a clinical matter, right? Because I think you'd need anthropologists and sociologists there to say, okay, we're aligning the research, but how does this align with our social and cultural understandings of race and who is included in these groups? And also, what are the effects? What would be the effects of shifting changes in some cases if there's a coordination, right? Would that mean shifting the way that clinical care has been practiced, or who has been categorized in some places versus others, and what kinds of impacts would that have, right? So some of the corrections that I'm, most concerned about and talked about today are the ones that reproduce some of the existing patterns of marginalization that we see in medicine, right? But in other cases, there are some people who argue for, we should have new racial corrections that try to sort of advance or correct for the health injustices that we see in the system, right? So ways that we should proactively or intentionally include clinical corrections, again, not based on folk ideas of racial differences and biology between groups, right? But actually based on current injustices and inequities in the system. Could we actually create those kinds of coefficients, right? So that, I think, would also be something that would need to come into play in a kind of international coordination, because again, the patterns of marginalization, discrimination would be different and would have different effects depending on the context in which these coefficients are used.
Thank you. I think, and Kevin, please say something in the Q&A if I'm incorrect. I think you've just addressed one of Kevin Cropper's questions about sort of flipping that script and using coefficients like this to address the reflection of structural injustice in healthcare rather than the other way around. Joe Ali asks, well, first he says, wonderful talk, Dr. Ferryman. Thanks for pushing the broader conceptualization of ethics in data science. Data science often happens out of view of the public. Do you have any thoughts on how to further advance connections between the important work of data science and public and community needs and desires?
Yeah, that's a great question. And I think, when thinking, one of the points that I tried to get across in the data, right, is that one of the problems with relying on data representativeness as your sort of sole or main way to address data bias, right, is that it doesn't provide additional context, information, history about the data themselves, right, which then, can lead to a lack of sort of, different ways of sort of interpreting the data, right? Because there's a process of kind of interpretation that happens as well. And so in the talk, I call out, the need for anthropologists, sociologists, and historians to be involved in this process of providing some of that context and history. But I also think, engaging wider sections of the public are also ways that we can get some of this important history and context of these data sources, right? So, for example, I think one kind of concrete way to think about this would be that we have a sort of institutional structure that's already in place in many places, the Community Advisory Board. And now, there are many people who have, good things and bad things to say about community advisory boards that, function and include community members in biomedical research. Some people say, it's a good first step. And I'm reducing the kind of debate here, right? Others say, who gets to be, tapped as a community member, and are they really representing fully the needs and views of that community? So with those, with that kind of debate in mind, I do think that kind of institution that's already in place could be used in other ways. And one of them could be in this way of providing some data interpretation, context, history. Because, for example, right, to say if teams who are developing, a new AI tool for, let's say, a particular hospital, right? Instead of one way to approach a group like that could be to say, okay, here's our tool. Can you sort of be users and tell us what are some of the, problems or issues with using this interface or things like that? But another way, right, could be to involve a group like this earlier, more upstream in the process to say, okay, this is the data that we're using, right? Tell us about how this data is actually collected. Like when you go into the hospital and people, ask you about this data, what are some of the conditions in the way? Are you even asked about this data? Is this something that is filled out without your knowledge? And I think those kinds of questions and ascertaining some of that information about the context and the history and the way the data is collected and used could be really important, and a way to bring in sort of a broader array of people into this really important task, I think, of historicizing the data, and also bringing to bear some of the important sort of current experiences of how that data is collected. So that would be just a start, I think, community advisory boards.
Great. John Noel Viana asks another question about how do we sort of open up public and academic scrutiny of the diversity of data when we don't have access to the data, because in papers, there may be a summary table, but you don't have access to the full data. And then if you do have access to the full data, how do you balance data access and transparency with individual privacy?
Yeah, that's a great question, right? Because that's a great question. So let me think about this. So one, with this question of transparency, right? And when thinking about, and it sort of comes back to the sort of threads of this this kind of data ethics that I tried to kind of sketch out, right? That's sort of related to, but distinct from a kind of what we think about as a traditional bioethics approach. And transparency in kind of data ethics has been held up as, an important way to make data collection and analysis more ethical by being transparent, right? Publishing the data. But again, transparency, I think, is not, shouldn't be our only recourse, because you can be sort of transparent, but there are degrees of transparency, right? So for example, if we think about going back to the risk calculators, right? You could see the clinical data, but if you didn't know that those data were already corrected before you sort of see the data itself, right? Would that really be transparent or not, right? So I think that transparency, to really get to the kind of meaningful transparency that I think the commentator here is asking about, I think it really does have to go hand in hand with some of these kind of processes of contextualizing and historicizing the data, right? Because it's almost like we won't know what really is opaque about the data until we get some of this additional contextual and historical information. So I think that transparency efforts should really be paired with some of those processes, and that transparency could again kind of start from the place of, well, this is what we have, right? This is what we could make available right now, but what else is sort of embedded or hidden in there that that could use some that we could do some additional work to sort of make this transparent in on a more deeper level, let's say. Then practically, right, we can think about sort of the history of transparency of data and biomedical research and some concrete ways that has been pushed forward, right, with things like journals having policies around how much data, should be published or made available when papers are published and things like that. And so I think there are some some practical ways that we can sort of get to more transparency. But one of the, I think, really interesting puzzles to work through is as we start, when we start thinking about different kinds of tools like machine learning, for example, right? Transparency of the model, let's say, is maybe not possible or not really that kind of meaningful transparency that I think that the commentator is sort of wanting, right? So even if the data, even if there could be a way somehow to sort of represent or be transparent about a machine learning model's data and what the model is actually showing, right? Like, would that actually be meaningful transparency? So I think that these tools actually provide us with a really good opportunity to rethink transparency and what that actually means and what it would look like, right? So that maybe, we could see, okay, if we can't get access to the data, maybe the push is not to see, well, let's keep pushing in that direction. Let's try to get more data. Let's try to get, the data tables. Maybe it's actually taking a step back and actually questioning, well, what do we actually really want to see? What are we trying to get to with this transparency? And maybe there are other ways that we get to that meaningful transparency that maybe isn't publishing, the data, especially if we can't get it. Not to say that, we shouldn't try for that in all cases, but I think it does provide an opportunity for us to sort of rethink how we can get access to information in ways that may be different from the strategies we have today.
Terrific, thanks. It sounds like we have lots of sort of structural issues to work on here.
Absolutely, yeah.
Jonathan Flores asks, are you aware of any specific grassroots initiatives or organizations that are focused on working towards addressing racialized data?
Yes. So, like I said, in the clinical community, there have been sort of a number of, in the past year or two, really been ever since this history, as I said, sort of goes back at least a decade or so, but in the past year or two, there's been sort of a flurry of activity around of sort of reevaluating some of these, many of these racial corrections that are used in medicine. And the EGFR is one example, but there's also another example that I didn't include the talk, the vaginal birth after cesarean calculator that also had a racial correction that has been changed. So in that case, there's a sort of another correction formula that's used that doesn't include race and has been found to be has been found to be accurate without the use of race. And so I think across, at least in the US, and speaking from the US, I'm not as sure about internationally, but at least in the US, there has been over the past few years a lot of increasing attention to really going back and reevaluating these calculators and the evidence behind them, their accuracy, but also some of the downstream effects of using these calculators, right? Because one sort of ethical conflict that emerges is that in some cases, these calculators, in some cases, right, they're not accurate or, they're just maybe not very good. But in other cases, even with the racial correction, they might actually be accurate, right? They do accurately predict risk in different groups, let's say. But so the question has been, all right, do we sacrifice accuracy because, there's this movement to think about race or take race out of calculators. And like we've seen with the VBAC, the response has been not to just say, well, this calculator actually works and it does, a good job at estimating risk, so we don't need to change it, but to say, okay, yes, this may work, but can we find another calculation that works just as well, potentially without using race and potentially without having some of those downstream effects that we see can be harmful. And there's also the sense of, right, if we're again thinking about calculators that sort of functionally have the same effect, but are there other kinds of benefits that we can think about? So if there are two calculators, one that uses race and one doesn't, and they're both, equally as accurate. And again, this is one of the points that my colleagues and I are thinking about and writing about, is there's also a benefit to be had in sort of removing this idea from these calculators. The other benefit is that it sort of begins to move away from this idea of race as a biological construct, right? And there has been research showing that, very recent research showing of, medical students still attaching, biological understandings to, racial groups. So there is that other kind of benefit, right? That even if you say, well, it's not that using this racial calculator really does, limit access to certain, procedures or ends up with worse health outcomes, there could still be a benefit of just moving away from this idea that's implicit in some of these calculators of these kind of innate biological differences between racial groups.
Thank you so much. We've had great engagement from the audience, but in our last couple of minutes, I just wanted to ask Jim and Kara, Tony, David, if you have any questions that you wanted to raise.
Yeah, thank you. I do actually. So first of all, very thought-provoking talk. So thank you for the presentation. So I was just going to ask, if you look 50, 100 years out, and you ask kind of where are we going to be? Are we sort of, going through a transient here where we're going from sort of an old perception of humans and, kind of, we look at ourselves externally and describe ourselves in very, phylogenetic ways to, to a world which is going to be much more detail oriented, genomic and proteomics, give us insight as to what the instruction set is we have available and maybe even how it's being used. The second, maybe even telling you something about how your environment, is affecting you. So I'm kind of wondering, is this a transition problem, or do all of those things that I'm talking about, potentially make things worse?
Yeah, that's a great question. And I think that, when we look ahead, right, so we do have technologies like all of the omics, which I think are giving us important information about human bodies and how they work and how information is, used and transferred. But I think just like, if we look historically where, again, some of the science that went into building some of these calculators, right? It's important to think about as there are scientific sort of innovations, right? That we have a kind of our social scientists, our historians sort of right alongside, right? And I think that is how we get to a place in 50 years where these same tools, same ideas, or these new ideas, right, could be sort of deployed for and have some of the same, effects that we're seeing now. So I don't think it's that, in other words, I don't think it's that, well, if we just get to better information, more precise science, that we will, leave the problems that we're having now and in the past behind us, right? I think it's essential to pair these kind of developments with knowledge from, social sciences, the kind of interdisciplinary knowledge that we know is sort of really important for pushing the science forward.
Well, we're constantly dealing with unintended consequences, I suppose. So it wouldn't be, we would be foolish not to expect, so at any rate, I'll just say thank you again. And thank you, Deborah, for letting me jump in with a question there.
Of course, of course. Humans are fantastic at creating problems for ourselves. There will be no shortage of that 50 years from now. So I want to respect everybody's time. So I just want to thank again, Dr. Kadija Ferryman for her fantastic talk and wonderful Q&A. And thank you to the audience for your participation. I look forward to seeing you at future IAA BI seminars.
Thank you, everyone.